Yeah, let me just start. We'll be dealing with endophthalmitis and endophthalmitis vitrectomy study. So this is an important study. Even, it's been 30 years still. The study is quite popular, isn't it? Every speaker is talking about EVS. You know why? The reason is this is a major prospective RCT that we have till date. That's why it's pretty popular. But remember one thing, this study was conducted, in the United States across 20 states, and they recruited only patients who developed endophthalmitis following cataract surgery. If you're somebody who would use EVS guidelines in your patient who has traumatic endophthalmitis or fungal endophthalmitis, you are fundamentally wrong. This is something you need to understand. And so EVS team had two things to begin with. They wanted to know whether giving IV antibiotics would be useful or not. And they realized that it's not really helpful. And then they wanted to know whether which is better, whether vit tap is better or doing vitrectomy is better. Typically, the name core vitrectomy, we traditionally call it, was coined by this EVS team. So when they call core vitrectomy, it means you need to clear vitreous, at least 50%. So you clear 50% of the vitreous, you just see the disc and then stop it. That's a core vitrectomy that they were talking about. So they realized based on the presenting vision was the only thing that they considered. So if the patient has up to hand movements or better vision, there is no difference between whether you do vit tap or do core vitrectomy. There is no difference. And if the patient has PL vision, then you are supposed to do PPV for all patients. That was a strong recommendation that EVS team had put forth. And even today, people follow that. This was 10 years down the line. This man, Ferenc Kuhn, Dr. Ferenc Kuhn, everybody must be knowing this man. He was asking, why do we still follow EVS? It's only the comfort that we are, that drives everyone to follow, vit tap more than anything else. Because, you don't have to operate these patients in late hours, and the vit tap is something which you can get it done in, it's office-based procedure. It's many places. So it's a comfort which drives, people to follow EVS. That's what he felt. And nothing has changed even today. 2023, this man, Dr. Fernando Arivalo from Johns Hopkins University is still asking the same question. Do we have to really follow EVS guidelines? Is it still valid? So, this is where we stand. Are we really justified doing, following EVS in today's era? We need to really look at this. EVS typically used, that time they had 20 gauge vitrectomy and then they had only 600 cut rates, per minute. And then you can imagine 1995, what kind of visualization system that they had. But today you can imagine we are operating at 10,000 cut rates, even why not 20,000 we have right now. And then we have excellent fluidics and we have brilliant, panoramic wide angle visualization. And we have moved to 27 and 25 gauge vitrectomy. So you can, you need to keep this in mind. And if the strongest argument against doing early vitrectomy, right from those days, it's the fear of causing iatrogenic trauma and development of endophthalmitis. So if you see, but even in the medical group, the TAP group in EVS study, the vitrectomy rate was quite high. That is something we need to remember. So introducing this concept called SEEV, or complete and early vitrectomy for endophthalmitis. It's been popularized by Dr. Ferenc Kuhn. Recently has published his 10 years data from 2007 to 2017, which we'll be discussing shortly. And so basically the steps of SEEV, when it comes to endophthalmitis, the recommendation is, you become like, you assume the role of an avenger. So the surgical goal has to be the complete removal of both infective as well as inflammatory material from the eye. So as against EVS, if you see the goal of surgery, main aim of EVS was to obtain vitreous for microbiological specimen and then create some space so that you can comfortably inject intravitreal antibiotics. That was they are primarily different. So, starting from, it's like deep sea diving. Starting from cornea, if it is easy, you may scrape. If it doesn't work, you may replace the cornea, do keratoplasty, whatever, but get access, go inside. I typically used to put multiple ports in the anterior segment, go inside. Endo eliminator is a useful tool. You may aspirate, cut, clear everything over there, and then get an access. And then you may at times want to remove the lens or IOL if there is a need really. And then when it comes to vitreous, starting from AVF, you go down, and if wherever possible, you induce PVD. and only in the periphery when it comes to shave vitrectomy, which is also recommended, but exercise caution over there. You should not cause any iatrogenic trauma. As safe as possible, you may want to do shave vitrectomy. It's still okay, and then you may consider injecting oil as well, and then intravitreal antibiotics. Let me show some of the videos here. So at Chennai, Aravind Chennai, we essentially follow this. Only thing, it's slight modification. We are still unable to do vitrectomy on the same day because of logistical reasons involved in it. So when we see a patient on the day, we advise surgery. So it will be done on the next working day, so to say. But on the same day, we tend to inject most of the time. So it will be most of the times it's one injection followed by vitrectomy on the next day. So that's how it works. But at times we do operate on the same day. This is one incident where this 7-year-old boy from Andaman was seen in our OPD on a Saturday at 3:30 p.m. And then the boy was intubated at 6:30 p.m. and we did the surgery till 8:30. So that was, something, when it comes to endophthalmitis, we need to be a bit more aggressive. So this was the case. I prefer to put, you can see it's a frank endophthalmitis, and then you see a lot of fibrin membrane over the lens over there, crystalline lens. And we wanted to really save the lens. We are trying to, remove the fibrin over there. We're using a 5 cc cannula. Just push a little bit of fluid and try to aspirate and sort of, take it gently without disturbing the lens. And, you can remove it as much as possible and send it for microbiological examination. So I'm using the forceps to gently tease it out. And if it doesn't work, you can use a cutter to, remove it. And, please make sure that your tip of the vitrectomy cutter is facing up and your infusion is taking care of the AC dynamics over there. And, when we went inside, after that, trying to clear the vitreous in the AVF, taking care not to, injure the lens, but you can see the view is pretty hazy. So we decided to, knock off the lens eventually. Only thing, you need to alter the settings over there. You need to go down in your cut rate and suction as well. And then it's essentially, since it's a small boy, essentially is aspiration more than cutting. So you do that and go inside and you get a slightly better view. Still the cornea is not great. So a little bit of shave vitrectomy and PVD induction as well. And that's how, we ended the case. I think we injected oil as well. So this is yet another case where we had to, So you can see here is post-cataract endophthalmitis and 3 ports and go inside. So we're trying to do vitrectomy from the AVF, and when we saw some exudates over the lens, definitely we thought you can see some sort of a membrane over the IOL. It's above the IOL. Then we decided to remove that. As I said, I tend to put multiple ports even in the anterior chamber. You can see I'm using the 5th port here just to get an access into AC with the good fluidics in the AC. I'm trying to remove all those membranes. Then you can see the excellent view now. The view got a lot better. And you can see now that a lot of surface exudates over the retina posterior pole. And you can see using with the cutter, vamos. And then you can use your flute cannula, hard tip. I'm using the hard tip here, but you need to ensure that you don't damage the retina. If you're doubtful, you can use a soft tip. And then some of the exudates were a little adherent. Then I used soft tip as well, as you can see here. So that's how we ended the case. And let me show one more video. So this is a interesting case where we had to deal with endophthalmitis as well, along with infection. Again, 3-port and you can see here doing vitrectomy at the AVF level, and then the retina is completely detached. Still, I could not really understand this was it because of necrosis or iatrogenic, but this was a post-phaco case where peribulbar injection was given, but you can see weird string, a kind of an exudate, but really could not identify any primary break over the retina. So eventually decided to do a drainage retinotomy, and then we settled the retina and did 360-degree laser and injected oil as well in this case. This patient is doing really well with 6/8 vision. Very soon we'll be doing the oil removal. So yet another case I would like to show where, when you see this kind of eye, you'll wonder how we can get an access and go inside. But as I said, Endo Illuminator is an excellent tool. I'm trying to see using the endoeliminator and trying to remove that thick fibrin membrane. The post-trauma case where surgeon has done, anti-segment surgeon has done OJ repair. And you can see a little bit of, they've done lens aspiration, but a little bit of lens is still lying over there. I'm trying to do lensectomy along with vitrectomy. As you can see here, I'm aspirating all the inflammatory debris, which is under the, it's in the post-hyaloid space. And then you can do a little bit of PVD induction and clear the vitreous. And I was injecting PFCL to safeguard the macula and then do lensectomy, as I said, reduce the cut rate and suction, complete the lensectomy. And whenever you're doubtful, when you're not sure of the periphery, when you do shaving, if you feel the retina would be necrotic and expect some sort of a necrotic tear, and it's always good to inject oil and close. This is another case. It's a small clip. I would like to show how, this one-eyed patient with following a trauma. This is how he presented. The cornea surgeon had done scleral tear, which was in the superior, above the superior limbus. And then I'm trying to go inside. There's a thick fibrin membrane with hypopion. There's a adherent leucoma with corneal degeneration. We're trying to get an access inside with the endoeliminator. We're trying to remove that membrane first and see what we can do best. So aspirate and cut it, and you can send it for microbiological examination. Still, it was very difficult to get an access, and then decided to do a little bit of, kind of pupilloplasty over there, and started to cut a little bit of iris and the material over there, and we got a little bit of an access, and then we did endodiathermy to ensure that there's not much of a bleeding, and then we proceeded with vitrectomy. Yeah. So I'm coming to the results of SEEVE study. As I was talking about, there was a 10-year study where they had included 62 eyes. So out of the 62 eyes, they presented that they found out that 79% of the eyes overall achieved vision of more than 612, whereas in EVS, I think it was only around 50%. And then again, HM or beta group, 88% at 612 vision. This was drastically different from what EVS has found. And in fact, the rate of RD was also pretty less. It was only 6.4% as against 7% in, even in the WIT-TAP group in EVS. So the strong recommendation from this group is, if you can see the fundus and if you can see the macula and if you are sure that the macula is LD, then you can give injection. If you're not sure, if you can't see the fundus, you can't see the macular status, please go ahead and do the vitrectomy. That's a strong recommendation. That's pretty, fair enough. And in fact, even in EVS, the most common cause for poor vision in EVS, according to EVS, is maculopathy. Endophthalmitis, maculopathy. We need to keep that in mind. So this is an interesting thing, SEEVE plus. So when you are, despite your, early vitrectomy, if you find the media clarity is deteriorating, the patient is, slipping down, then you may have to, repeat your vitrectomy, do vit lavage, do probably oil tamponade, or repeat your intravitreal injection. There is no, standard number or anything, but the media clarity should be good. That's a, message. So thank you.